This conference will now be recorded.
Okay.
Great. Well, today we'll start off the TASC 90 with an update from the Federal Office of Rural Health Policy from Sarah Young and Makina Scott. And I'll turn it over to Sarah and Makina. Star 2 to unmute your line. And there's your slides.
Thanks, Sally. Do you want to go first, Makina? Are you on?
Hi, sorry, I had to do the star 2 button. Can everyone hear me now?
Yep, loud and clear.
Okay, great. Okay, great. Sure, so I'll go ahead. A couple of quick updates as far as the policy side of things. The first update is more of a reminder. I'm sure that pretty much everyone by now, most of the flex coordinators have heard about the proposed rule for critical access hospitals, and I know Sarah put out there the updates, and you've heard a lot about this at the recent meeting last month. So more so that a reminder that the comment period for the hospital and critical access hospital changes to promote innovation, flexibility, and improvement in patient care proposed rule is going to be closing soon on August 15. And again, of significant importance for critical access hospitals in this proposed rule is recognition of the MBQuip program as a national quality measurement and reporting program. So it would, again, require COS to collect data to measure the quality of care that they provide, and participation in MBQuip would be a way to meet this data collection requirement. So again, that the comment period for that particular proposed rule is coming to a close on Monday. The other policy update that I wanted to bring to your attention is this new bundled payment for cardiac care and hip fractures. So earlier this month, on August 7th, on the 2nd, CMS published this proposed rule for bundle payment models that really trying to address high-quality coordinated cardiac and hip fracture care, similar to what they did for under the comprehensive care for joint replacement model, which began earlier this year in April. So under this proposed episode payment model, a hospital in which a patient is admitted for care for, say, a heart attack or bypass surgery or surgical hip or femur fracture treatment would be accountable for the cost and quality of care provided to Medicare fee-for-service beneficiaries during their inpatient stay and for 90 days after discharge. And so for the new cardiac bundles, hospitals in 98 randomly selected metropolitan areas will be required to participate. So it is a requirement for hospitals in these areas to participate in the bundled care model. Now, what does this have to do with critical access hospitals? Well, most of the rural counties basically are excluded from the model, but hospitals can, work with providers and suppliers such as critical access hospitals and providing this discharge, post-discharge care. And so the proposed rule talks about, how hospitals can move forward with having that type of collaboration. It would be more so of a contract between such hospitals in these required locations, as well and with the provider or supplier that may be providing this post-discharge care. So, and there is a indirect way, I guess you can say, for critical access hospitals to participate in this proposed bundle payment model that CMS has published. Now, CMS is proposing that the first performance period would run from July through December of next year, July 2017 through December 2017. Also of note for this proposed rule is that CMS is opening the opportunity for suggestions for future condition-specific episode payment models or event-based types of episode payment models for procedures or medical conditions that could be applicable, that may be more applicable for rural areas. So I wanted to just really highlight this as an opportunity for you to kind of take a look at that, and especially the role that critical access hospitals can play in providing some of this post-discharge care in these bundled payment models. And also, if there, are thoughts from any of the other providers that you work with and the hospitals you work with on what are some conditions that are more applicable to the critical access hospitals that CMS may want to consider for bundled payments. I've provided the link for the proposed rule, or actually you can go on the Federal Register and find the proposed rule, and comments are due by October 3rd. The other thing, too, that I wanted to highlight is that we do have a new policy email inbox for questions. I mean, I know we tend to put in our newsletters and through updates like this, updates on the various regulations and policies, and if for some reason you may not have questions at this time, this is an opportunity for you to come back later as you get questions, or maybe are reading through some of these proposed regulations and guidance that CMS puts out there. You can send questions to us at ruralpolicy@HRSA.gov, and we will try to triage your questions and answer them as best we could, or find the right person either here in our office or at CMS to address various questions that you may have related to the policies and regulations coming out that could affect critical access hospitals. So I think I will stop there. Those are my brief updates.
Thank you, Joaquina. Does anyone have policy questions for Joaquina while we have her on the line? And if you can't press *2, you can type your questions in the chat box.
Can you repeat the email address for questions?
Sure. ruralpolicy@HRSA.gov. ruralpolicy@HRSA.gov.
Thank you.
Thanks, Joaquina. Those are two proposed rules that are potentially significant for cause, so it's great to highlight them here in this forum. Hearing no other questions, this is Sarah Young, the Flex Program Coordinator here in the Federal Office, and I'll give a couple of really brief Flex Program updates. As Sally noted, we just had the reverse site visit 3 short weeks ago, so I don't have a lot to share right now. I do want to say again, I hope everyone has filled out the assessment for the reverse site visit, and that was a SurveyMonkey link that you should have received by email. And as well as completing your communicating the message activity. Both of those things are really important for feedback on the meeting and for helps us because we're in the federal office. We need the assessments that TASC does and the feedback on your activities to help show the beneficial impact of having grantee meetings like this. So I really do appreciate you putting a little bit of time and thought into both of those things. Other program updates, of course, as you all know, where Omid is starting out as our new project officer, mostly handling states in the Southwest region and some parts of the Midwest. We're really glad to have Omi on board with the Flex team. And then finally, this was both in the Rural Route newsletter, and Mike sent an email update to the mailing list last week, but I just want to say one more time, save the date for a webinar that's now 2 weeks and a day away on August 25th at 2 p.m. Eastern Time to review the upcoming Flex Notice of Awards, reviewing the program requirements, how to read that in OA, and how to understand the terms and conditions that you might find on it. Speaking of notices of award, they're definitely in process. Many of you may have seen the obligation in OAs come through by email, so those are not new funding awards. They're part of the way FORHP processes the finances to move unobligated funds from a prior grant year to make them available for reaccessing, as it were, in the new Notice of Award. So that is a standard part of the grant process. And you may see one of those come through your inbox. Just take a look at the grant budget period to which that in a way applies, and you can quickly tell that it's a retroactive action that doesn't impact your current work. And like I said, in a couple more weeks, you'll be seeing the new funding notices of award come out. So with that, that's all I had to update on at this time. Are there any, do you have any questions for me? And remember to press *2.
Thanks, Sarah. There's a question, about the NOA webinar that overlaps with the Regency meeting.
And Nancy, yes. Thanks for asking, Nancy. The webinar will be recorded, and it will be recorded just like this one and posted in the Flex Program Forum as soon as Nicole can process the recording. Any other questions?
Thanks, Sarah.
Thank you.
And we wanted to just remind Flex coordinators that the CMS hospital quality star rating through Hospital Compare was launched, and the Rural Quality Improvement Technical Assistance, or ARQITA, Stratus Health did prepare kind of an overview and statement of the star rating and how critical access hospitals are reflected in that. And their summary is posted as a resource on our site, and they sent that out through our All Flex list 2 weeks ago. And just to note, the 1,332 cause, only 540 had a star rating. So there's more than half did not have a rating because of the low volume for a specific outcome or process of care measures. And so if an individual or patient goes to that hospital, in many cases it's going to be blank. However, the good news was for those who did have a rating, the mean for critical access hospitals was 3.31. So that was slightly higher than non-critical access hospitals, which had a mean of 2.99. And CAHs are pretty narrowly distributed from 2 to 4 stars. And actually only 102 hospitals nationwide had a 5-star rating, or 3%. But just, I think FORHP and our KEED are just curious if you are hearing from your hospitals that there's something in the local media or state discussions within CH meetings and such to share those comments or media with FORHP and our KEDA. Okay, I'll turn it over to Alex Evanson from the University of Minnesota with the Flex monitoring team, and he'll be providing an update.
Alex is going to be on the line in just a minute or two. He was delayed.
Okay.
Hey, Sally, this is Sarah again.
Go ahead, Sarah.
Since we're waiting for Alex, I'll break in and say that actually I just got an update that some of the new funding awards are already going out today. So I don't know that they'll all be out this week, but you're going to start seeing those in your inboxes.
Okay. Great. For the Flex NCC Awards. Okay. And we have found that if you don't see it and you're expecting it, to check your spam box because sometimes it's the unrecognized email and might go into the wrong box. So if it doesn't come, be sure to check.
And that email will come from the HRSA OFAM DGMO NGA email box, just to keep you confused.
Yes, not from Sarah Young or
No. It's a system-generated message. And also, if you're expecting something and don't see it, check your contacts that are listed in EHB for that grant, because the notices of award are sent to the program director and the other grant contacts that are listed in EHB to receive new NOA emails.
Thanks, Sarah. And Alex, looks like you're on the webinar. Star 2 to unmute your line.
Oh, can you hear me?
Yep, go ahead.
Oh, hi. Hi, everybody. Sorry, I had to call in late. I got a call that I had to take really quick. The Flex monitoring team doesn't have a whole lot of new products or anything to update you on. Summer is a slow time in academia, but we do have a policy brief and longer briefing paper focused on the community benefit spending of CAS of the rural and urban hospitals coming out in the next couple of weeks from the University of Southern Maine. And any day now we expect to go live with the hospital compare quality data on our Compass system. That's what we've got. And as always, if you have any questions about our products or anything else that we're working on, you can always email me using the Flex Monitoring Team website.
Great, thanks, Alex. Okay, we'll move into the findings from the Rural Provider Leadership Summit. And we're excited to present the findings from the summit. And with me is Terry Hill from the center, and also two participants in the Rural Provider Leadership Summit, John Barnett, the Michigan Center for Rural Health, and Paul Kleberg, physician from Aledade, will also be joining as participants and sharing some perspective. So the Rural Provider Leadership Summit was held by the center, and you know that the center provides a variety of technical assistance and resources within the transition to value and population health. And TASC has definitely moved into responding to that transition to value and population health for critical access hospitals, and how Flex programs can support their hospitals and rural communities in that transition. We also provide services and education in the Small Rural Hospital Transition Project, funded by the Federal Office of Rural Health Policy, as well as two projects here in Minnesota with our Medicaid State Innovation Model and an integrated behavioral health project with the Minnesota Flex program. In terms of collaboration and partnership, we are the Network Technical Assistance Center for many of the network grants within the Federal Office of Rural Health Policy. And in performance improvement, we support the Small Rural Hospital Improvement Program, grant program, funded to states and then out to up to 1,800 small rural hospitals. And in health information technology, the center through TASC, continues to convene the HIT Rural Health Information Technology Coalition, and that's been meeting for over 10 years now and tracks issues within rural HIT adoption and optimization. And finally, in workforce, the center is the Minnesota member of the 3RNet and supports also some of the workforce-related networks.
Sally, let me just say a word here, and that is to encourage folks. You know, there's a lot of resources within TASC itself, but we do encourage you to go to the other program pages where there is a substantial number of resources on network development, for example, under that program supported by the Federal Office of Rural Health Policy. A lot of very applicable hospital performance improvement resources under the Small Rural Hospital Transition Program. And so if those of you, some of you, particularly those that might be new, there's a lot on the TASC website, but do explore some of the other areas as well, because particularly when we're talking about transition to value and population health, our other programs are all pretty much focused on that as well, besides the support for performance improvement and networks, etc. Everything is moving now in this direction with our federal funding.
Thanks, Terry. So today our objectives are to learn the drivers and challenges related to engaging rural providers and value models. And from the summit, we'll be exploring the strategies for engaging rural providers in value and population health initiatives. And finally, discovering resources for state flex programs used to support rural provider engagement, and hearing from two of our participants at the summit. And the summit was supported by the Federal Office of Rural Health Policy. It was convened in May in Bloomington, Minnesota, and the purpose was to identify strategies for rural provider engagement and transitioning to value-based models. And this was conducted within our cooperative agreement. And our project officer, Mike McNeely, participated, and it was great to have Mike there and bring the perspective of overall the hospital state division within the different grant programs, but also the potential connection of these findings to their community-based division and policy division and the Office of Advancement for Telehealth. And we really commend the federal office for looking forward into the transition to value and how this is impacting rural hospitals, networks, communities, and providers, and how the goals of HHS to move towards value-based purchasing and population health and need to kind of also adapt to the cost-based reimbursement programs we have for the critical access hospitals, community health centers, rural health clinics. And the center has held several summits supported by the Federal Office of Rural Health Policy through TASC. We've had summits on population health and critical access hospital finances, quality, networking. Last year we had one on flex leadership and developed the core competencies. And most recently also this year through our SHRP program, we held one on financial leadership as well and released those findings recently too. So our objectives of the summit as we reached out to potential participants, we indicate to them that we'd be identifying the opportunities and challenges related to engaging rural providers and value models. We would work with them to identify and prioritize the strategies and actions rural hospitals can take for engaging rural providers and value and population health initiatives. And we would be asking them to share examples of models from their state or their region and helping us identify resources to support the implementation of these strategies. And these were our summit participants, and the a variety of states represented. We had 2 hospital CEOs, 4 physicians, all family practice physicians, and we had 2 networks represented from Missouri and Minnesota, and one of those networks, actually the Healthcare Collaborative Rural Missouri, actually owns 2 federally qualified health centers, so they actually employ physicians. And Kathy Johnson from Dynamic Advantage, former CEO at the CH, also created a 3 CH network, Lockheed Paro Health Network. We also had a nurse practitioner, who's an instructor as well from Alaska, and Gary Wingrove representing community paramedics and EMS. We had 2 state flex programs, state offices, Michigan and South Carolina. Foundation that focuses on health leadership, and from Rural Health Value, another Federal Office of Rural Health Policy program. Carla Wang participated, and actually Carla did quite a bit of the scribing and writing of the findings. And here's a group picture, and behind us, that wall with all the pieces of paper was the work that was created. We used sticky walls. For those of you who may have been to one of our workshops or meetings or conferences, and it's really an interactive facilitation style to engage everyone in the work. Terry's going to provide some background of really even why we decided to convene the summit as part of the TASC program this year.
Right, and basically it's very clear to us, it's increasingly clear to our rural hospital leaders. I can assure you I've just seen a relatively steady movement on the part of hospital leaders into this recognition that we are entering an entirely new era here, driven partially by the Accountable Care Act, but also partially upon the fact that we have pretty much reached the end of our patience with patients. I mean, from having patients with the outcomes that have increasingly gotten worse in terms of quality, marginal quality at high cost, et cetera. So with the Affordable Care Act and with the direction of the entire industry now, we are moving into this new era. You've probably seen this before. I do want to basically emphasize it again, and that is simply that we are, the federal government has laid out a route pretty clear from Secretary Burwell that by 2018, and last time I looked, that was about 1 year, 4.5 months, about 50% of the reimbursement for Medicare and increasingly in Medicaid is going to be out of these advanced payment models, the accountable care organizations, all of these new models that are being tested across the country. You can see that 90% figure there is the total amount of the payment that is going to be somehow related to quality. And if you really look at what would those 10% outliers be, we're talking about the perhaps the critical access hospitals, the FQHCs, federally qualified health centers, and the rural health clinics. At this particular point, we're not quite sure what to do with them in that regard, but I wouldn't count on them staying outside of this curve here for very long. We know that in 2016, for example, we've already exceeded the goal. There are now over 30% of the payment coming on Medicare, for example, that's going into ACOs and these other types of value-based population health models. And we're already, to my understanding, out around 85% of the payments now being related to quality, cost, and not so much with population health yet, but that is very definitely coming as well. Now, one of the reasons we expect that we're going to hit that 90% by 2018 and that 50% as well is making it perfectly clear that if you're not in a rural health clinic or an FQHC, if you're a provider, you're going to be in the value-based game. By 2018, for example, all non-RHC and FQHC providers, particularly physicians, are going to have to choose one of two tracks. They're going to go into track one, which is the MIPS payment, which will basically provide this incentive that grows larger every year in terms of potential bonuses, or penalties which grow greater with every year after 2019 as well. So it starts at 4% bonus, 4% penalty, and then it gets larger moving forward. So that's MIPS, and one of the things we're doing here at the center is really digging into this deeper. Obviously, this is something the National Health Association is doing, and some of the other organizations as well. But we really want to understand this payment model and get a feeling for exactly what the impact is going to be on our rural hospitals, our rural clinics, etc. The second track is in these new payment models that are basically associated with accountable care organizations, for example, or some of these new demonstration models based on value and population health. Those are the only two options if you want to get paid under Medicare Part B. Again, assuming you're not in a rural health clinic or an FQHC. So this is going to have a huge impact, and it means that the relevancy to this particular conversation, it means that our physicians, the ones that we have in rural America, are going to have this choice. And we've seen several kind of the national thought leaders indicating that it's their understanding is that the second option, or track 2, which leads physicians into ACOs, and that also includes nurse practitioners, PAs, etc. Far more lucrative from a financial standpoint, is far less hassle for maybe the individual organizations themselves. And so the prediction, I can just tell you, if you go onto YouTube, you can find a lot of really good videos on that. The predictions are physicians are primarily going to go into the value-based models, and so it's something absolutely we need to prepare for. What we did also is, during the discussion, the initial stages of the discussion, we used this, we created this from the input we got from the participants themselves. And we said, let's ask the folks, what are the market driving forces here that are moving us towards greater provider engagement and value-based models? Because what we know is our providers are extremely busy. Our perception is, and the ones that I've talked to, just haven't taken a lot of time to think about, where they're going to be 5 years from now, what that's going to mean to their practice, etc. So let's take a look at what is driving them, and then let's take a look at what some of the challenges are here as well. So we have these state innovation models. It's the SIM grants, for example. We're seeing these. Oregon has a really very interesting program where they're dividing up their Medicare payments into regional entities, and so we're seeing this happen. Minnesota and Colorado have done a lot of work in this area, and then we have the SIM grants. Washington has some tremendous things going on as well. ACOs and other alternative payment models, we're seeing a huge force here and in terms of 41 new rural ACOs as of January 1st of this year. We're anticipating many, many more moving in that direction. I know, for example, Texas has plans to launch quite a number of rural ACOs that we're seeing those plans happening in other areas as well. I've already talked about MACRA and MIPS. It is a huge incentive. You know, it's this concept of finance is going to drive form and function here, and physicians are getting thrown into the middle of this. Increased data transparency. Again, it just providers or folks in the public sector, our patients, etc., are going online and finding scores, you know, star ratings. If you want to analyze the quality of physicians, for example, that has been launched, etc., with star ratings. There's just a ton of stuff that's coming on that's kind of you know, meeting this demand for transparency. Patient and community expectations. I mean, the rural can't be the second rate provider here. Already our quality scores, as we've seen, can be better than urban centers, but we can't be second rate in terms of access to the information, et cetera. So we have these community expectations, and we can't sit back and wait for everything to settle, the dust to settle, so to speak, as we're moving forward. The new generation of providers, that's one we hear all the time, and in terms of our new providers don't want to spend you know, every waking hour supporting their patients, etc. They need a balanced life. I think the characteristic of the new generation is simply going to mean they may have a lot of other attributes, but we're going to have a provider supply here, and we're going to have to cater to the new folks coming out, just as we cater to the new nurses in the younger nurses, etc. And then there's going to be increased consolidation. We've seen that already with our insurance companies, as we've gotten down to 3 basic health insurance companies. We're going to see that in the systems. I know, talking to some male leaders, they're predicting that we're going to see massive consolidations here as the big systems that can't get their act together basically will be taken over by other big systems as well. So those are the market driving forces, and then the transition challenge, basically saying in rural, we don't have a lot of money. We don't have a lot of investment capital. One of the things that came up in our financial summit meeting is that our bottom lines, as we're investing into new infrastructure, you know, aren't going to. We may suffer on that. We may see that instead of a positive financial performance this year, we're going negative because we have to make those investments. It's something we don't have a lot of money. The leadership is tension between survival and transformation. If we have a hospital bleeding financially, it's very difficult to talk to them about what they need to do to transform the population health. all their energy goes into finances and trying to keep the doors open. There's the change fatigue. We're piling this on top of electronic health record adoption and new quality reporting, etc. Limited data capabilities and lack of interoperability. Again, this is something that's probably going to require a lot of work to make sure that we're getting the kind of data and information to make changes here. We're going to have to somehow integrate our electronic health records, etc. Population shifts and out-migration. This is a significant issue. I want to really emphasize it. A lot of the folks in our community are leaving for services they could be getting locally. It was one of the big takeaways from the National Rural ACO experience. They're losing a huge segment of their market, and that's very clear just looking at their Medicare data, and it's leaving. So we've got to make sure that we capture, particularly in the outpatient side, shortages of providers and expertise, and then just kind of limited time and the need to establish trust in these new relationships. Now, we always use frameworks because we believe that provides a kind of a multifaceted approach, taking all of the key drivers and resistors into account and create almost like a systems framework. The two that we discussed and used in this particular summit meeting were the Performance Excellence Blueprint, which you all know, but I'm just going to take a second to look at it. And then something that was produced by Rural Health Value, written by Dr. Clinton McKinney out of Rural Health Value in the University of Iowa. And Dr. McKinney, who I think many of you know, is a practicing physician, works with that research center, and is really a leading spokesman for not only rural health value, but for rural physicians in the country as well. So what we have there is if you go into Dr. McKinney's report, Physician Engagement of Primary or Healthcare Leaders, you just click in there and you will immediately get Dr. McKinney's report. And I'm going to talk a little bit about it now, but I do encourage you to read it if you haven't already read it. This is our Performance Excellence Blueprint based on the Baldrige framework. And again, what we find over and over again is we look at this, it's about how do we engage leadership, how do we measure and develop. If you think about the path to value in population health, all of these key pieces are going to play a crucial role, and we have to take them into account. We have to measure them in terms of strategic progress, and they've all got to come together if we're going to achieve the kind of outcomes that we're looking for. The other piece is the physician engagement characteristics, and this comes directly from Dr. McKinney's report. I want to just talk briefly about it because what we wanted to do, this came out before our summit meeting, but this is really focused in on physician engagement, particularly focused in on how to get physicians engaged. And our report is more strategies or recommendations to our Medicare Flex programs, which we did under TASC, to maybe the hospital association. It certainly could be useful for physician leaders or hospitals as well, but we just wanted to make that distinction. Dr. McKinney is a physician. His report is written directly for physicians or to hospital leaders, and we didn't want to duplicate that, and we used it as kind of a starting point to make sure that we didn't duplicate it. Under those 4 areas, they include governance, and what's recommended by Dr. McKinney is we've got to get physicians actively involved in governance because they are now key to remember primary care physicians in particular are key to success in value-based models and population health, and absolutely essential for accountable care organizations. Not only their buy-in, but their partnership. Then we've got to get them actively involved in governance as well. As Dr. McKinney said, physicians want to be in the room. They don't want to be outside looking in. And he talked about getting them on boards, having physicians involved in strategic planning. We have examples of dyad leadership. We have a local system here in Minnesota where virtually all their major departments have dyad leadership. A physician leader and a hospital administrator leader. So that's one tactic. Also, that rural hospitals should be considering chief medical officers if they don't already have them. And that is something over and above just chief of staff. This is really somebody who is a kind of a part of that hospital and is a key leader there. The second piece was education, and the recommendation was that we get physician leadership and management education available. If we're going to involve physicians in governance, if we're going to ask them to do more leadership, then we really have to get education out, and a recommendation that we also do some mentorship, that if there's a physician leader in an ACO, for example, that we find another mentor for that person, particularly if they're just starting out. Third area was compensation. One of the things that I think is very predictable, and we're already seeing it happened, if you look at Jackson Coker and some of the other folks out there, primary care physician salaries are going up. They're going up considerably, and probably what's going to have to happen is surgeons and other type of specialty salaries may inevitably have to come down a little. So that's a key part. But rural hospitals have to understand that we're in a different era now in terms of payment in order to be competitive for a finite supply of rural physicians. We may have to pay a little bit more. Also, paying for measurable behaviors like value-based compensation, compensation for serving on committees, for example, knowing that, because of when they're production-oriented, physicians basically lose money if they're not seeing patients. And then finally, data that physicians are data geeks in their own sense. I mean, they truly are. They're scientists. They want to have data and information that gives them some assurances that we're making the right decisions here. And they also, another really good strategy here is to use comparative performance data, because physicians tend to be, according to Dr. McKinney, relatively competitive with each other as well. So those were recommendations coming out of that report. We truly suggest you look at it. And again, we had Dr. McKinney and Dr. Mueller from Rural Value provide input into this paper, and they provided a lot of input. So we truly appreciate them as well. Sally, I think I'm turning it over to you to talk about the outcomes of the suggested strategies.
Yeah, once we looked at the drivers and challenges related to engaging providers, we moved into what were the strategies to help guide rural providers in understanding the movement to value. And we narrowed it down to 10, and these first 5 are in the priority identified by the panelists. So number 1 was most important, and this list of 10 came from over, I was looking at the picture of our sticky wall, over 50 different strategies and ideas identified by the 13 participants, and then we clustered them together and named them, and then put them in the priority order. So these strategies that were named have more detail behind them within the findings report, and we'll share that link in the end. The first one, most important, was creating a shared vision of value and understanding the role of providers in the transition, and the participants felt that hospital leaders need to be willing to invest time and resources to help provide education on the changing healthcare environment and facilitate those discussions that lead towards a shared vision of value. And as Terry just talked about from the physician engagement characteristics, that involving providers in governance and taking time for education, you are pulling them out of clinical duties, and also bringing in providers that may not be employed by the hospital, but other key providers in terms of nurse practitioners, EMS, paramedics, behavioral health providers, that it's important that that vision of moving towards value for the community is understood. The second one was examining the various models and approaches towards value, and that leaders need to actively seek the funding and the technical assistance to support and develop the implementation of value-based strategies, and engaging their providers to determine what's the most feasible model to address the unique needs of that rural community. It could be the ACO investment model. It might be the Medicaid state innovation model in your state, or both. It could be looking at grants from the Federal Office of Rural Health Policy or grants.gov that allow some initial networking and care coordination. It could be working with the transition clinical practice initiative, or TCPI, funded by CMS, and all the different technical assistance available through that program, or now the new in 14 states through the comprehensive primary care plus that's available for primary care providers to move into that one. So it somewhat depends on what state you're in, and is your state covered by some of these, but then also who else is in your region and what's happening in the market. The third one was investing in provider leadership. And again, once you have that vision of investing time and money and education, and that goes way beyond just the financial reimbursement. Every practice has a thought leader, and become you might be a champion who will help see the future and can work with the hospital leadership or even within your state flex program, within the networks that you have, to identify that they have that interest and passion and can help align other providers moving towards value. And one of our participants said that an employed physician does not equal an engaged physician. So just because the hospital has these providers on payroll doesn't mean they're all automatically engaged. And again, the transition is happening so rapidly, and there's different models that it's important to invest that time between providers and the board and staff and the other community leaders to share the direction that hospitals going. The fourth one was partnering with others to capture and share data. And several of the summit participants shared stories related to the critical role in capturing data, the difficulty in doing that consistently and accurately, and sharing that with providers to engage them, and access to claims data. That has been a huge gain for those who have joined ACOs, that they received the Medicare data, and it was cited as eye-opening. And also with states that are doing Medicaid, community care organizations or accountable communities for health. Again, that Medicaid data, claims data is shared with the clinic, the hospital, but that needs to be shared with providers. One of our participants said you have to share data shamelessly with everyone, even the public. And number 5 was develop collaborative relationships and connect community resources to address patient needs. And there was a growing recognition that many of the factors that impact illness and healthcare spending are outside the scope of traditional healthcare, the clinic and the hospital and EMS, that mental and behavioral health needs are significant in those with chronic health conditions and socioeconomic factors, and even individuals' habits and behaviors all have a more significant impact on the patient's well-being and their ability to improve their health or manage chronic illness. And then the next 5 strategies to complete our 10 were not, insignificant difference in terms of priority, in terms of sequencing. It was more in terms of the process. And the sixth was redesigning operational processes for value and population health, and having that true focus on improving efficiency, effectiveness in hospital processes can really set the stage for implementation of strategies that expand to include a focus on value and improving community health.
Sally, if I could just, an example of this would be extending your clinic hours, maybe to, to 8, 9 o'clock, being open on the weekends, etc. I think those strategies to capture additional market share would be crucial here as well.
Yeah, e-visits, using your portal, and helping community members access the portal if there's low bandwidth, and lean was brought up too as a process improvement technique used to really look at improving efficiencies. 7, developing skills and organizational capacity for team-based care. So important as we look at all of these alternative payment models have an emphasis on care coordination, and that's very different from what our primary care providers were trained in the educational process. And we're working with others, maybe outside of the clinic walls. So defining those roles and really distributing the tasks across team members, that there's a true delegation, but good communication to reflect the skills, the abilities, the credentials that can increase the ability of providers to improve their care, as well as at the same time helping reduce provider stress and frustration that they may be feeling from working within an electronic health record for providers that are over 40 and weren't educated with an EHR right there. and I had that they need to still kind of, it's second nature. It's not normal to, or it's not second nature to sit with a monitor in front of them with the patient and be clicking through.
So I wanted just another comment. That I get that question more than anything else. It's like, where are we going to get the money for that? You say you're going to team, well, the money is within, the for support for providers. There's money within an accountable care organization for providers that are so. Believe me, there is. I mean, you can't just make this stuff up or go with existing resources. There will be enough money that's built into these financial formulas to get that kind of help to talk.
Mm-hmm. And then the incentives from the improved outcomes from patients. And then 8, seeking opportunities for collaboration and synergy with other providers in organizations. And here the participants talked about it's the importance of participating in rural networks, membership organizations, or other affiliations within their state or region, or even nationally across states that offer opportunities to interact with other professionals facing similar challenges, and really moving from our patient to that it's our patient, not just my patients within my practice. And number 9 was telling your story, and the participants noted that because we're so early in these models, that it's important that providers and hospitals share their challenges, but also their success stories, and encourage and inspire others to move across the shaky bridge, or move into the other canoe, and help influence policy and rulemaking. And number 10 was advocating for rural payment policies that adequately address rural community needs. And Terry noted we've all seen the goals in terms of HHS, the moving fee for service to quality-related payments, but so many of our rural providers are critical access hospitals or cost-based reimbursement for Medicare and quite a bit of their Medicaid. So they're undergoing significant changes. So we need to be sure we're advocating for rural payments that make sense within these new policies. Well, now we're going to invite 2 of our participants to share some perspective on position in a state office rural health program that is also working with the hospitals in their state on these COs. And Terry, will start with Dr. Paul Kleberg.
let me introduce Paul, Dr. Kleberg. Dr. Kleberg is a primary care physician who practices in Minnesota for quite some time. He's now medical director at Validated, which is an accountable care organization, basically working across the country. It's a physician, accountable care organization. Dr. Kleberg was also the medical director of our regional extension center. That's why we got to know him well. He is a national leader in health information technology, but he's also somebody that now is very directly involved in this movement into value and population health. So, Dr. Kleberg, first, maybe I'll just give you a chance to talk about kind of your story about what Validate is doing and anything else you'd want to share about physician involvement or engaging physicians, and then I'll ask you a few questions after you've made a short statement.
Sure. Can you hear me okay?
We can hear you fine.
Oh, good. Yeah, Validate is an organization that's been just around for about 2 years now. We partner with primary care practices to help them form ACOs, and in that process of helping them to form ACOs, we were actually able to get a lot of the data